I'm Richard Walker, Executive Director of the Benjamin Rush Institute. We hope you enjoy today's edition of the Benjamin Rush Institute's Virtual Events series. This series would not be possible without the support of foundations that endorse the mission of the Benjamin Rush Institute, our student chapter members, and individuals like you. Through your support, we are able to continue informing and educating today's medical students about the benefits of patient-centered, doctor-focused methods for the practice of medicine, just like those discussed in this series. I encourage you to visit our website to learn more about the Benjamin Rush Institute and the medical students we serve. While you're there, please consider a donation to support our educational programs and events just like this one. You can donate by card, check, or by mail. Thanks for your support, and thanks for watching the Benjamin Rush Institute's Virtual Events series.
All right, so we're at 6 o'clock, so I think we're ready to start, David. I want to thank everyone for signing in here today. I'm Peter Bentavegna, and with my help from Dr. Ira Redzo, we are also working on putting together the Benjamin Rush Institute second talk for New York Medical College chapter. I want to introduce David Ring, MD, PhD. He is an Associate Dean for the Comprehensive Care and Professor of Surgery and Psychiatry at the Dell Medical School, University of Texas, Austin. He is trained as a hand surgeon, orthopedic surgeon. Dr. Ring's extensive research, patient care and quality, and patient safety leadership contribute to an understanding of and passion to the way the mindset and circumstances affect human illness. Getting people interested in innovating ways to get and stay healthy depends on effective communication strategies that establish trust and make healthy habits appealing. Dr. Ring's current work focuses on ways to use existing knowledge, diverse expertise, and innovative applications of technology to help people choose healthy options consistent with their values. I know Dr. Ring for a long time through New England Hand Society and our associations with Mass General Hospital for the last 20 years, and he's now gone for 5. We miss him terribly, but so happy to see him back today. He's going to bring to us, like he did to our society, best practices, clinical relevance through evidence-based medicine. David, thanks so much for coming on.
Yeah, thanks for having me. Hi, everybody. I was told that I appreciate the interests of the group in communication strategies and patient-clinician relationship, and then also technology. And I thought, I've got the talk for that. So there's a lot of ways to package my interests and my research, and this is the way I packaged it for a South by Southwest talk. That's a Austin conference that used to be music, only pretty much music, and now it's become largely tech. And so this is how I packaged a talk and got accepted. And now I'll give this talk to you because it seems to suit, and I think it can hit a lot of important topics, whether you're a clinician or a patient. It's got some interesting stuff there. So the patient in this case is going to be me for the most part. So this is me living in New England with a rash, and my wife notices it, my daughter notices it, and they say, maybe a bug bit you or something, or what do you got going on there? And I just kind of blow it off for a while, right? And then after a couple of days, it starts to become a little bit of a concern. So I had a symptom or I had something going on, but it really wasn't an issue until it became a concern. And then, so what do you do when you get a little worried? You Google it. So even a doctor, it's like, well, let me check it out. And so I was a little worried about Lyme, so I kind of looked for that. But I didn't think it really I didn't think it really matched up. So a couple more days passed, and I looked again. I'm like, well, mine doesn't really look like that. So, but I have a friend who's a dermatologist, so I texted her, and she's like, David, you idiot. And so this is a symptom became a concern became a text became a diagnosis, and then across state lines, she's in Massachusetts, I'm in Rhode Island, she's able to give me a prescription for doxycycline. So quick as that, super convenient. It might have even been a weekend. I'm getting my Lyme disease treated. And, it cleared up really quick, and I realized, boy, I'm feeling a lot better than I was that last week. So I was kind of adapting to a sort of flu-like symptoms without even realizing that I had this. So this is a quick anecdote for how medicine could be and how technology plays a role. I'm using the internet, I'm using text, and I never spoke with my dermatology friend, and she was able to electronically put in a prescription across state lines. So this is all the things that I experienced in this little episode. I experienced the ability to. I experienced access. I experienced convenience. I had trust. I had some trust in Google and Google Images and the web, and I had a lot of trust in my friend who's a dermatologist, and I got a cure. But I also got peace of mind, and I was in control. I was able to continue in my life. I never had to exit. It was not really inconvenient to Google the images and the information. It was not really inconvenient to text my friend, drive over to the CVS and pick up my doxycycline. And I was completely in control. This is what we dream of medicine being. Let's see what happens when one of my patients, I'm a hand surgeon, so one of my patients gets numbness in their fingers. And they go and they get this diagnosis checker. And so the first thing they get is this sort of complex, there's a bunch of ads, there's a bunch of distractions, and there's very little useful information on this page. And then if you focus in, I'm going to pull this out for you to read more closely. And the hyperlinks are the things that your hand numbness might be. Diabetes, alcohol abuse, stroke, oh my God, multiple sclerosis. So you're immediately like freaking out. Like you were unsettled enough to Google it, and now you're really unsettled. I may have multiple sclerosis. I may be having a stroke. So this is now going the opposite direction of my experience. And you can go in and put in your diagnosis checker. And again, it pops up heart attack, multiple sclerosis. And you notice how it's not very easy to read. You're probably looking at the slide and going, this is a terrible slide. What's he trying to tell me? Well, that's what the website does too. It's like, how do you find the information? You're getting distracted and tempted to click on Ask a Doctor, and they're trying to scare you and get you to misclick and end up in the wrong place. And it's just not super friendly. And another way that technology or innovations are happening is that medicine is now showing up at the CVS. It's showing up in these places, and when the way it shows up is not. It's not what I experienced. It's not. This is going to be easier and more relaxing for you. It definitely is better access, but what happens, and there's actually evidence on this. That what happens is and I don't know if you see this in New England, but I definitely see it in Texas. So if by the time, let's say somebody jams their finger and is worried about it, what will happen to them is they'll go to a CVS or an urgent care, and they'll be seen by a non-specialist who will say, gosh, this could be bad. So they'll worry about it a little bit more. I'm not an expert, so I can't reassure you. And that looks swollen, and I don't like the way that looks. And they get an X-ray, and the X-ray maybe shows a fracture, but for hand surgeons like Peter and I, it's a volar plate avulsion fracture. It's a nothing. It's just a sprain. But they can't tell you that. They tell you your finger's fractured, put you in a splint, and they say you got to go see a specialist. Well, they can't get right to a specialist very easily. They go to their PCP. They go to their primary care doctor. Primary care doctor says, "Come on in." They get another X-ray because they can't see the X-ray taken at their urgent care, and nobody gave them their X-ray. So now they've got two X-rays, and the primary care doctor says, "Yeah, you've got a fracture. You got to see a specialist." So they get a visit to the specialist. They come see me. I may not be able to see the X-ray. May have to get a third X-ray. And finally, I say, "Oh, this is just a sprain. You didn't really need to do any of that. You could have actually looked it up on the internet and and texted me and not being seen." So this is the opposite so technology doesn't necessarily by default make things easier access, peace of mind, self-efficacy, and save you money and time and effort. It's a dream. It's an ambition. What could happen is you go to the CVS and the non-specialist says, "I cannot reassure you about this, but I know who can. Push this button and you'll get a video consultation with a specialist." And that's got convenience, potentially lower costs, less waiting time, better experience. You have to spend less time worrying, less time driving around, you get fewer x-rays. But we've studied this and we've experienced it now with the pandemic, that people have a bias that care happens in person. And they have a bias that if you're across Zoom like we're doing today, it can't be warm, it can't be caring, and something will be missed. And if you can't examine me, then you can't do your job properly. Plus, they're worried about technical issues. Some of you maybe I'm freezing up for you or coming in and out. And then they worry about privacy issues and logistical issues. So it could be great, and there's some great ways we could use it, but there's some barriers that are going on. So here's what I did to try to ameliorate this. I did this when I first got to Austin. It's a beta, it's just like a simple idea of what could it be? Like somebody's got finger numbness, or let's just use finger numbness, but it could be anything in their arm. It's an arm problem. So you go Google it, you go, "Oh, it's an arm problem," and you go and you can click numbness and go in there and try to figure it out yourself. But look, there's no ads. It's all very hierarchical. Like you're not going to be overwhelmed with information. You're going to be given, it's a tree. So let's say I click on numbness and I read it. I say, okay, first of all, you got to make sure, people say numbness, sometimes they mean pain. So numbness is tingling in the fingers falling asleep, difficulty feeling things. And then there's this numbness diagnosis tool. Or if you're already pretty sure you've got carpal tunnel syndrome, you can just click on that. So it's very simple, no scrolling. Health literacy is not an issue. Reading level is not an issue. And you can click if you want more. So here's a diagnostic tool just based off of basically SurveyMonkey, or in this case, Google Forms. And first thing it does is distinguish between true numbness and using the word numbness for pain. And then you can go through to diagnostic tests, and then you can say, "Hey, I think you've got carpal tunnel. Try wearing the splint at night." And basically you're giving care away for free, and you're giving people access to, it's pretty simple. You can diagnose yourself with carpal tunnel pretty easily, and you can treat yourself, and you can know when you need to have, if this splint stops working, see a specialist, you probably need surgery. And if it doesn't work, if you go through this simple website and you're still like, "Gosh, that didn't satisfy, I'm still not sure what I have," or "The diagnosis guesser told me I don't know what you have, and I just don't trust what was said," or any of that, let's do a little text chat like you do when your computer's not working or when your order didn't work out on Amazon. You go on this text chat, and me, the clinician, I could probably run, just like a customer service person runs 12 chats at a time, I could probably do the same thing while you're thinking about what I said or going to look up some information I directed to you to, or you're typing in your next thought. I'm helping the next person. And then if that doesn't work, you can send me a picture, send me a video, or we can hop on a video chat. And I think this is the future of medicine. Now, I'll put in a little anecdote here that I was just hearing from my emergency medicine colleagues here in Austin about how they've handled things in the pandemic. And the gist of it was that they found that people were less likely to come in the height of it. When we were really worried about things in March, April, and May, people would be having a stroke or a heart attack and they wouldn't come in. And so they would come, people that had ankle sprains or, the worried well, sniffles, were not coming in. So the emergency room was relatively empty, and the people that were there were high acuity, they were sick. So they were working harder because most of the patients they were seeing were sick. and they were a little bit delayed in their presentation, and they didn't get a breather. They'd love to see somebody who's really, really sick and then go see an ankle sprain. They were saying, I missed that. I wasn't able to do that. It's just sick to sick to sick, and including the people who were sick with COVID. And what they ended up doing, because they couldn't get access to specialists, so they started using telemedicine for specialty care, and it's been working great. So if they need psychiatry advice, if they need orthopedic advice, they use telemedicine. And we've been doing that in New England. We did that. We do it here in Austin. If you've got a hand that you think might have to come down from Maine to Mass General because it looks bad, it's been cut up bad or injured bad, they send us text and we talk on the phone, or we trade texts. And a lot of times we prevent that unnecessary helicopter flight, maybe do it by ambulance, or just have them see the local hand surgeon on Monday. And that's becoming now mainstream. And what it gives people is it restores their hope pretty quickly. It gives them independence and control. Technology like virtual care, email, portals, done well, I've already said it can easily be done poorly, but done well, it gives me a chance to interact with the person many times over time. And then Atul Gawande has called that incremental care. And incremental care, for those of you, clinicians know, I might see somebody and I'll tell them, hey, here's what I see. And my diagnosis is completely unexpected. And so there's this threat to the relationship where I'm telling them that their reality is not real, that they've got to shift the way they think about it. So I need to be gentle with that, and trying to get it all done in one visit, real threat to the relationship. So it's nice to be able to say, let's do a phone call, trade some emails, do a portal message, or do a video visit, next week. You just think about it. We'll get together next week. I've even made this work effectively for people who were really pressuring me for an answer. Let's talk tomorrow. I need a moment to gather my thoughts. And they want to press me to get the answer. I just need a moment to gather my thoughts. And then the next day, in most cases, things are a lot more relaxed and it goes a lot better. Certainly a week later, that is true. Greater accessibility, and people sit in their home doing video visits and realize, wow, look how easy this is to get to the specialist. We could do this as often as we need, and it's super easy. And it's easier to gently correct these misconceptions over time, help people become aware of their values, build a relationship, and the hierarchy is leveled because they're sitting in their own home, and so they feel more comfortable. They feel like a kind of a more willing to speak up, more willing to. It's a position of power for them to be in their comfort zone, and it levels the playing field between clinician and patient, and people are more likely to speak up. So I think technology. I'm a huge fan of telehealth, and I've seen it do a lot of good. Now we're going to get on to the part where we talk about how technology can help you with your human foibles. And the human mind looks for patterns. So look for the lung nodule in this chest CT. Try to find the cancer. And this study was done building on a very famous psychological study, had chest radiologists look for the cancer, and they often missed the gorilla. I don't know if any of you, probably some of you have seen the famous experiment where the kids are passing the basketball back and forth, and you're supposed to count the number of times the basketball's passed, and about half of us, a little more than half of us, miss a gorilla come walking into the screen, beat his chest, and move on. I missed it when I did it. And so smart people miss it. It's called selective attention. It's a form of cognitive bias. It's the way your mind uses shortcuts and gets things done. And you have to be aware that your mind does this. And the scientific method is built around this. You want to catch your errors, and you want to make sure that other people aren't tricking you. And so this is me again, when I first got to Austin, I wiped out on my mountain bike riding along the river. And at first I thought I broke my scaphoid, but later that night my elbow started hurting and I was pretty sure I had a radial head fracture. But it was clicking. I have had a radial head fracture before when I was 16 skateboarding in California, but I felt a clicking on the medial side, and I was like, oh no, maybe I have a coronoid fracture. I know too much for my own good. So I got my motion back within, I never really lost my motion. I kept moving even though it hurt and was tight. I knew to do that, but the clicking was making me worried. So I got access to a mini C-arm and took a look, and you can see a little fracture here, and it actually looked a little bit worse in a different plane. Now, what if I were to go to an orthopedic surgeon to get care for my fracture? I would be told different things by different people, and there are actually trends by region. And so what I might be told that the fracture is displaced and that there is incongruity of the articular surface. And I might be told that if I'm not happy with my clicking, which I still have a little bit of residual clicking in there. I can feel the clicking right now. If I might be considered to have failed non-operative treatment, and that surgery might be required. So I want you to notice the language here. It's not the language of accommodation and health, because although I have slightly less motion in my elbow than I did before, I could hyperextend before, so I don't miss it at all. And although I have a click that I notice in certain positions and with certain activities more than others, I'm accustomed to it, and it's my new normal, and it's not an issue whatsoever. So my dash score would probably be a 0, and I don't consider myself damaged or ill. But my elbow is definitely different. And if I heard words like this in my early decision-making moment, I might be more likely to choose surgery. And so this is very important stuff. So how do we get people out of this morass of who's talking to you and their incentives and their values and their worldview and their biases are now placed upon you? How do we undo that? Because surgeons are not the best communicators, and I'll raise my hand and say that, and I think Peter's heard me talk about that before, that I am a blunt, matter-of-fact person, and that's what makes me a good surgeon, but it makes me a terrible communicator. So I have had to practice and become aware of my incompetencies there, and all the skills that I could get, practice them. I still practice them. I'm still not perfect, but I'm much, much better than I was. And, I'm not alone. There's no shame in this, because orthopedic surgeons are at the bottom in terms of communication strategies and communication effectiveness in the ratings nationally. So there's no reason to be ashamed. Now, this is an example of a test that uses skin conductance to measure empathy, and you can measure physiological effects, and this may actually be a lie detector test. I forget which one this is, but basically you can measure physiology and try to correlate it with things. And this is the skin conductance one, and you'll see that when you're experiencing pain, there's a certain physiological reaction, and when you're talking to other people about their pain, you also react, and that's empathy and compassion and connection. There's a connection that happens and a synchronicity that happens with people when they're talking about their suffering. And you may or may not be aware of that. And so I think as clinicians, you can think of the time when you're with a patient that's really upset about what's going on, and then you start to feel upset as well. They were really pressing you to find an answer and be efficient and get to the answer as quick as you can, and you start to feel that pressure as well. There's technology that can measure this physiology, whether it's heart rate, respiration, depth of respiration, sweating, skin conductance, and like a Fitbit type of thing. And the technology is getting better and better. Now it's down to a ring that can do this. And we just these can all be tools to train you to be self-aware that you're noticing something in the patient. And we recently did a study where we aimed a camera at the clinician during a clinical visit, and so we were aiming at the clinician, and what we were mostly interested in is, does the clinician's facial expression of emotions create a better experience? And we measured perceived clinician empathy, and there wasn't much of a correlation there. But secondarily, we asked, does the physician's facial expression of emotions correlate with the patient's emotions in terms of despair or depression, and worry or fear, which is anxiety, but also in terms of misconceptions, cognitive biases, cognitive errors, like pain equals harm, hurt equals harm, and fear of painful movement, worst case thinking. And it turns out that the clinician's facial expressions are very synced to the patient's mindset. So the correlation of catastrophic thinking to certain aspects of the facial expression, emotional aspects of the facial expression, was 0.6, which for those of you who do much research or statistics, that is a pretty strong correlation. And so what that does is that creates an ability to become more self-aware. You might not, I think this right here is actually, probably those of you who have dogs recognize what this is. This is a dog collar that you can set up a perimeter, and if they go beyond the perimeter, they get shocked. So they learn to stay on your yard. And I always talked about jokingly that if we put some monitor on me when I'm not a great communicator, I may not make the right choices when the communication's getting difficult. I may not even realize that the communication's getting difficult. I may not even realize that I'm losing the relationship with the patient, but my body's realizing it, my mind's realizing it. I'm just not conscious of it. So then if it shocked me or like tickled me or buzzed me or something that reminded me to, hey, take a step back, stop trying to solve the problem, just forget about the medicine. Don't worry about the medicine. You're losing the relationship. You're losing the patient's trust. Work on the relationship. Medicine's for tomorrow. And that's what we need. So if the facial recognition thing says you got to make sure you realize that this person has a lot of important misconceptions, and they're kind of hopeless and they're kind of worried, at least to some degree. Pay attention to that, get the relationship going, get back to that. There's another thing that we can do with technology, and that's present the information in a different way, in a non-biased, dispassionate way. So we've got that map that shows that we're doing it differently. We're doing it regionally differently. Peter's doing it differently than I'm doing it. Every patient deserves to have the full information in a way that they can sort it out. They can figure out what their values are, what matters most to them, and then they can match it with the best evidence, and then they can get those matched up and make a choice. They shouldn't have my bias or the way I explain it in the way. If I explain it in a way that doesn't help them clarify their preferences or doesn't help them understand their options and the potential harms of each option and the potential benefits of each option, then maybe we need a decision aid, something like this. So here you can see, I think this is for radial head fracture. This is for my radial head fracture is what this is for. And there's a little quiz that will catch common misconceptions and point them out to you. Like, you might be thinking this, that's not true. Make sure you don't decide based on a misconception. So radial head fractures don't need surgery to heal. They heal on their own. It's just to realign the bone, and you may not benefit from that. And then the next thing you can do is check in with your values and check in with what matters most to you. I don't mind having surgery as long as I get a benefit, and I'm comfortable with the risks of surgery. I don't mind a scar. So figure out what your values are. I mean, it's like, I don't want surgery. I don't want anybody cutting me unless it's absolutely necessary. If I can do pretty well without it, then I'm good with that. I don't want surgery. So you just figure out where you are and then reflect on it and do that before you make a decision. All right. So back to how this can increase compassion and care and actually improve care. So this is from a journal called the New England Journal of Medicine Catalyst, which is all about kind of innovative ways of treating people. And this is a dermatology specialty care. And they're saying, the reason there's a big waiting list for dermatology, and there was always a huge waiting list at Mass General for dermatology. I'm pretty sure there's a huge waiting list here in Austin. A lot of specialty care has a huge waiting list. And they said flat out, like, the reason there's a big waiting list is because a lot of people have things that really don't need dermatology care. And so they started designing smarter ways to get the information out of there. And I've shown you some things that we could use. So they would get an image, primary care doctor would get an image reviewed by the dermatologist, information back to the PCP, so an e-consult. And the systems are set up to incentivize financially, whether it's an alternative payment model or just an e-consult fee. You can come up with a lot of different ways to incentivize this type of collaboration. And then the dermatologist is only seeing the ones that they need to see. So for those of us who do musculoskeletal work, this is rheumatology. So when I have somebody who has rheumatoid arthritis, and I know that there's super good medications that are really good disease-modifying medications, they'll keep you from getting more nerve damage, they'll keep you from getting more joint damage, and my patient has to wait 3 to 6 months to see a rheumatologist, and they're already behind because of lack of access in many cases. That's just intolerable. And when you talk to your rheumatology colleagues, and it's because they're seeing people with fibromyalgia, which is a whole different thing it's the opposite spectrum of, clear pathology of rheumatoid arthritis, known pathology, and disease-modifying treatment. Fibromyalgia is totally opposite. So really, that's more about accommodation right now because we don't know what to do with it. So I think this can really solve this. And I'll go back to, and they looked at what they did. They were able to, have people not get referrals at all or have a low priority referral. And they were able to triage the ones needed to get in quickly and get them taken care of. So this is obviously a place where technology and it increases coordination, improves the care that's given in the non-specialty area, and improves the non-specialist knowledge and abilities with skin care, and then involves the specialist in a high utility way, like they're really being at the top of their license and they're being valued and they're being used. And we need to make sure that they're being fairly compensated for that expertise. And I could see a way where you could probably do so many of these little e-consults, particularly if it's asynchronous, that this could really work out quite well in terms of business models. So here's me again. I had this little thing on my elbow and I was getting a little worried about it, squamous cell or something. So I sent it off to another dermatology. But now I'm in Austin, so I sent it off to it's good to have a dermatology friend, another dermatology friend. He said, looks like this, don't worry about it. And I'm here to report that it is gone. And then I had this problem. And this one ended up I put off seeking care for a year. I got care. That's how I met my Boston dermatology colleague. It actually ended up being a type of pemphigus, which can be dangerous. This was a very mild one. And I took a leprosy medication, dapsone, and it cleared it up. And then I was doing so well, I forgot. I started missing doses, and then I was missing a lot of doses. And then I called her. I said, hey, I'm not having a problem. I'm missing doses. She said, try it without. And it hasn't been back. So me in medicine, trying to do as little as possible and learning from, kind of slipping up and finding out maybe I don't need the medicine anymore. Okay, so there is a part of health that is the story we tell about ourselves. Obviously, I tell the story about myself that I'm healthy, even when I'm not. And that can get me into some trouble. But in general, that's a good thing to tell yourself. You're going to be okay, even if you have these problems, even if you take a pill every day, even if your elbow's not quite what it was, even if your eyesight's not quite what it was, you are able to do what you want and reach your goals. And if you can tell yourself that story, you're healthier. And if you can't, you're unhealthy, no matter what the pathophysiology is. So there's an element here in health, and particularly in musculoskeletal health, and a lot of discretionary quality of life care, where your thoughts about what's going on and your emotions about what's going on and your behaviors in reaction to what's going on are key aspects of your health. And so you've got to know how to work your mind. You just like you have to know how to work your body. If you want to play golf, you need to learn how to play golf. You need to hold the club and swing the club and set up the tee and judge the distance. There's so much. You got to learn how to work your body. And you got to put, if you want to learn how to work out or get fit, you'd have to learn how to do the exercises for specific muscles. Then you have to do them. So you have to be coached, practice, and then train, and then execute. It's no different with your mind. People think that their mind just automatically works perfectly. That is absolutely not true. It's why we get educated. It's why we have a support system. It's how you learn from adversity in your life. And we all could benefit from mindset training. And I think the quicker that becomes cool, the better, because right now there's a stigma against this sort of thing. So here's the stigma removing slide, because everybody looks at those lines on top and thinks the middle one is longer. Everyone gets it wrong, because it's partly at the neuron level and it's partly at the processing level, but you get it wrong. So that's type 1 thinking or system 1 thinking, Kahneman and Tversky, the biases of your mind, the systematic ways you get things wrong. And then type 2 or system 2 is on the bottom, analytical or critical thinking. So to be healthy, you need to be honor your gut feelings, your intuition, your first draft. Honor it because it's often remarkably accurate, but don't trust it. Be a critical thinker, be an analytical thinker, and be ready to pivot, be ready to be wrong. Intolerance of uncertainty, inflexibility in thinking, cognitive fusion, where you fuse with your thoughts and they are facts, all very unhealthy. You need to be nimble, humble, curious, and open. So let's see if you can be curious and open. Here is a disease that I treat every day as a hand specialist. This is the prevalence. It's the age-specific prevalence. And notice that as you get above age 80, you can expect to have this problem. So if this is something that is very, very common, starting at about age 40, and all of you will have it. I wish this on all of you because it means you're living a long, healthy life. So think about what that could be. This is arthritis of the base of the thumb. So when you have this type of a base rate that everyone gets it, you know something immediately for sure. Most people accommodate it. So then the person who's seeing me in the office, if I take 100 people with thumb arthritis, which is essentially everybody over age 80 and most people over age 60, they're not all seeing me. There's no way that that can happen. There's not enough resources for that to happen. Let's just estimate that somewhere around a third choose to, where the symptom becomes a concern. Now, this is just symptoms, actually, the way I've set this up. So some subset notices their symptoms. A lot of people don't even notice their symptoms. We know that because we've studied it, that you can find thumb arthritis incidentally and people won't even have noticed any symptoms. And then symptom becomes a concern and then they tell a doctor. That's a smaller group. And then symptom becomes enough of a problem to tell a doctor and choose to see a specialist. And then the number of people that choose to see a specialist and have surgery. And there's a difference between the people in that small group and the average person with that pathophysiology. And that difference could be physiological, but it seems a little far-fetched. All the evidence so far points to what you're thinking, whether you're thinking unhealthy thoughts, and what your emotional, how much distress, worry, despair do you have in your life? How much social support do you have? How much security do you have? You have financial security, home security, relationship security, role security. So when we started to notice this difference between illness and disease, you'd have the pathophysiology, not even know you have it. We started asking questions and we found that, the answers were pretty common sense. The more distress and hopelessness you have and despair you have, the more symptoms you have. So how do you get people interested in that opportunity? For me as a specialist, they're not seeing a musculoskeletal specialist to be told there are ways that you could improve your accommodation. Nobody wants to hear that. It's a risky thing to say, and there are ways to do it, but it's risky. So I think technology could help here, and there's precedent. For more than 2 decades, they've been working. The Department of Defense has been working on developing avatars that deliver cognitive behavioral therapy for post-traumatic stress disorder. And they've gotten really good. They've gotten to the point where soldiers with PTSD actually prefer the avatar over an in-person therapist. And think about it, my understanding is in the military, you could say it's a very can-do sort of team-oriented. It's just hard. They're the last ones to say, hey, I could use some mental health assistance. And so they like to be private. It diminishes the stigma they face. And you can tell anything to a bot. You might not feel so comfortable with a person. And so and then this is going to get really sophisticated, because remember, with a facial expression, word identifying, natural language processing, picking up on those key words that you say, like unbearable, excruciating, can't even lift a coffee cup, I have a high tolerance for pain. You hear all those verbal signs, you see the nonverbal signs of misconceptions and distress. And then the bot will pick up on that, make some noticing, empathic, compassionate things that get you talking, do some motivational interviewing with you, get you to tell a story, and you're telling it to yourself, that helps make clear what's going on. So I hope I've made the point in several ways that technology, our gut feeling is that it's going to make things cold and impersonal, that it's going to decrease privacy and make us more uncomfortable in many ways. But I think I can point out to you that done right, it will be more equitable, more accessible. It will be more intuitive. It'll help people find their problem, understand their symptoms, understand their values, and choose among their options. It'll allow us to be more incremental, give people time, allow us to build the relationship, and it ultimately will restore hope and be enabling. So appreciate the invitation. I know that, I hope that is a good point of discussion, and I look forward to talking with y'all.
First off, David, thank you. That was really great. It made at least me look at technology in a different way. We usually look at technology when we talk about it with students and health leaders and so forth, in terms of let's look at all the way technology would work, like systemically, in terms of like decision making and algorithms and so forth. But looking at it in terms of how it helps patients and clinicians understand not only the ways that they're thinking, but the obstacles to their thinking, as opposed to just offloading thinking, was really beneficial. So I appreciate that. I know that we do definitely have a few questions. I can sign off and either let Peter moderate or you moderate, and not sign off, but go mute. And then if no one has a ton of questions that go over time, I can start asking as well, because you just got me very excited about the talk. So.
Jeffrey, I see you're unmuted. Did you have a question?
Yes. So the first is I wanted to compliment you, because I think that you presented this information in a way that was very meaningful. You answered a lot of the questions that I had before your lecture, just based on the topic. And there were a couple of questions that I had. If you can pick and choose. The first is, can you, what differences do you see generationally? That is, as a practicing pediatrician, we find that when we're sitting in a room with a patient, we're looking at a computer screen and they're looking at their phone, and nobody's looking at anybody. And in this particular case, you actually have two people looking in the same direction. So that may actually be a positive, but do you see a major difference generationally? The second is that a lot of your goals that you're trying to achieve were presented in a very interesting way, and they all revolve around empathy, and whether the empathy is created by AI, still the person that's doing the AI has to be empathetic per se. I mean, they have to understand the baselines of what empathy is. And counteracting all of that is this barrage of direct-to-consumer advertising from medicine that patients are looking at on a daily basis, and they're looking at it uncritically because they're looking at it while they're listening to the news, while they're watching their favorite show, while they're watching the ball game. The television is basically giving them a message that if you have cancer, you come to this hospital because we will cure it. We are miracle curers. And if you have a really terrible cancer, we will fix it, with the inference being that if you have a minor cancerous lesion that would be easy to treat, you should still come to see us. And the same thing is true that for any minor complaint that you should be using this medicine. I honestly think that direct-to-consumer advertising is directed at physicians as well, because they're hitting you when you're not being critical, and you come away with feeling that if somebody has type 2 diabetes, you should use this particular medicine. And they're actually hitting you, and while you're sitting and you're watching a news program in a non, I think the direct-to-consumer advertising is directed at physicians as much as patients. But there's this constant barrage that you have to be seeking treatment from the best possible source. And this may be a way of trying to combat some of that, but I'm not sure how successful it's going to be. And how do you see those two things playing off of each other?
Now, let me start with the second one and tie in the generational thing. I would recommend there's a YouTube video and also I think it was an article in Wired, and it's an interview with Yuval Harari, who is a historian who wrote *Sapiens* and *Homo Deus*, and really has a very interesting way of summarizing human history and in terms of human thought, and ties it very well to psychology. And then Tristan Harris, who was a former ethics advisor or director, or I think he worked for Google, and he was in charge of their ethics. And the two of them get together and talk about these issues that what they call it is they're more looking at the way that technology, it basically hacks your brain. So what they're doing, what people know, they're figuring out what they need to do to get you to click more, to stay on the website, to think of their hospital when you have cancer, to think of cancer as something you never draw the line on, you're always treating, there's all these things that they're nudging you towards that may not actually fit your values or may not actually fit the data. And they're basically hacking your brain. And the point that they make is you have to be aware that your brain is hackable. So I was talking about cognitive bias, cognitive error. So you are vulnerable to this. And then you have to cultivate your self-awareness so that you can be nimble and avoid the hack. So for instance, if you know that when you go to check, this is what happens to me. I'll just tell you how I get hacked. So if I go to the Weather Channel to check the weather, instead of weather.gov that doesn't have any ads, which is just as good, if I go to the Weather Channel, I'm going to probably click on the one that says like abandoned amusement parks. I don't know, sometimes Ghost Amusement Park, they get my attention. So I click on that. They know my clickbait and they give me more of that stuff and I click on it. So what I'll do is I'll say, I know how this works, and I know when I click on that, I probably get a whole bunch of cookies and I waste a bunch of time. But, once every third time, I'm going to go ahead and let myself click on one. And so you just know yourself, what they're doing, that they're trying to control you and that they're trying to hack your brain. And then I think now that's a long way from what the average person is going to do, right? So it's a pretty tall ask. And I don't know how you can read the article for what they think about how you might be able to do that, but it's a really difficult thing. And I don't think that those differences are generational. I think some of us are better critical thinkers than others, and some of us are more nimble and flexible in things that, like, you can conceive of what a medical care visit looks like, and then some of us are more nimble in in picking up, okay, maybe I can just do it by phone, or maybe I can do it by video, and that could work just fine. And some people are more open and nimble to that. And it's not really so much generational as it is just your mindset and your personality. We did a couple of studies where we looked at surgeon comfort with telemedicine, because almost everybody had a taste of it during the height of the pandemic, and this was international group. And we asked them questions like, if you were going to talk with correspond with a colleague, would you prefer a phone call or is an email okay? If you're going to have a meeting, is a virtual visit okay, or would you rather be in person? And the people that wanted to be in person and wanted to have the phone call, wanted to have that personal touch, they don't like telehealth. People like me who love virtual care, who love email, get a personal touch from an email. I love working with people by email. I love telemedicine. So you can find these aspects of your personality, and it's really not so much generational as it is personal.
Hello?
Yes, hi, I see you.
Yeah, I number one, I'd like to say it's good to know that you have a lot of skin in the game, so to speak, in your lecture.
Mm-hmm.
With all the diagnoses.
Most of my health problems are skin.
Okay. This is not my main question, but the last example you had with the virtual therapist.
Yeah.
How do they determine whether that virtual therapist is better matched with the patient vis-a-vis sex, Caucasian, Black, whatever? Because even though they should know it's a virtual therapist, that virtual therapist looked a little bit Asian to me and was female. And how do they match them up with the quote unquote correct virtual therapist? That was my first question. My next question, which is even more major, is I kind of thought the thrust, I'm a radiologist, and I kind of thought that AI in radiology is probably the greatest application of any of the specialties. And there are certain personalities that go into different specialties. Some of them want patient contact. Others, like radiologists, mainly do not. And the worst situation I would have as a radiologist is to interact with a patient. I'm not the primary care physician. I say something which triggers that patient, says, I do not know that patient. And then I cause trouble with the primary care physician who knows the patient, because they bring back the information to the primary care physician who doesn't know how to process it. And you've set something off which you can't stop at that point.
Yeah. So I've met with two groups that are working on avatars, and I haven't asked that question. It's a good question. My assumption would be that it's pretty easy to change the characteristics of the person, of the avatar. I think that's probably relatively easy these days, and that you could check in with a person like, who do you feel most comfortable, or who would you like to? I also think it's probably true that, just like in real life, you might want to try a few different ones and see which one feels comfortable. So I don't know if they do that, but I think they easily could, and they probably are. In terms of AI and radiology, I think it could easily keep you from missing the gorilla, so to speak, and catching your cognitive errors and cognitive biases. It's a nice tool to draw your attention to the things that need your attention, and maybe draw your attention away from things that don't. I think that when you're talking about whether you need an interaction, with the patient, I don't think it's going to be, I agree, imaging, whether it's skin imaging or radiology imaging, is really, computers can make a big difference there. I don't think they can now or ever will replace humans, but it's a great tool for humans. I would say in the radiology realm, the way I would apply this idea, the ideas in the lecture are words and concepts. So you generate a report that now, based on technology, people see. So your reports used to be only seen by the ordering physician and anybody else who looked at the record, but now they're seen by the patient. They're mailed to the patient, and they're on the portal, and so they're seen by the patient. And as orthopedic surgeon, I can tell you that the way we traditionally talk about an MRI report, for instance, is super unhealthy. So every signal change is named tear. So tear equals harm and damage. So if the major misconception of somebody in pain is that they're damaged or injured, you've just reinforced that misconception. And we'll often get the, hey, look, they told me I'm torn. So we've done some research on that we can get those words and concepts a little bit more aligned with getting people in the right narrative. So we can actually learn that by testing their reaction to various concepts and wordings and trying to get that right. And we can also do it by having technology look over the radiologist report, and maybe I slip in a piece of jargon that it suggests that I switch to plain language. Maybe I slip in the word tear just because it's so ingrained, and it suggests I switch that over to defect or hole or something a little bit less reinforcing of the sense that they're injured. So that's how I would apply some of the thoughts from the talk.
Can I just follow up?
Yeah.
It was always my understanding years ago, I've been doing this for many years, that visits to primary care physicians, something like 30 or 40% of them are psychosomatic, that there's no physical ailment. Now, I don't know whether that particular patient fits into that category and shows up with his primary care all the time with psychosomatic illnesses. So my interaction with that individual, the primary care knows how to deal with that individual. I don't know how to deal with it in conveying information, especially, let's say, mammography, where you put a seed in someone's mind and they obsess about it, and you didn't mean to do it, and you didn't understand who you were dealing with. So that's the worry I always have as a radiologist, not knowing the person I'm talking to.
Yeah, and that makes my point. Yeah, so you have no idea how this will land, so you need to make it landable for the worst case, somatoform disorder, deep depression, lots of cognitive fusion and misconceptions. I like that argument. I'm going to take that with me. That's useful. Like you want to make sure you don't mess up that situation, and you're relying on the person with the best relationship, as I do, that the primary care doctor knows them best and has the best relationship. I'm relying on them to help convey that. So I think that's a useful paradigm. Appreciate that.
Thank you.
If we don't have other questions, I can ask one
Sure.
question, and then we can follow. We can finish.
Sure.
So I really like the examples that you gave. There's one thing that's troubling me, and I'm going to fumble through it, and hopefully the question will come out. But it seems a lot of the examples that you gave are basically a technological translation of cognitive psychology, meaning like if you're an undergrad who takes cognitive psychology and then uses those skills to make good decisions in life. And when I mean make good decisions, means understanding your biases in terms of perceiving the world around you, and then taking that data and knowing how to process it to make good decisions, then you don't need the technology that you have provided in the examples. Moreover, there are people who prefer emails versus phone calls and telehealth versus in-person health, but there's also a big difference between taking a survey on what your values are and someone asking you what your values are in terms of the shared decision-making process. Mm-hmm. So how much is technology taking over a skill that still should be had by physicians versus supplementing the skills that physicians are having?
I love that question. And I can tell you what we've seen in our research. Yeah. So I showed you decision aids that we created. Two of my PhD students, Dutch PhD students, created a company that makes decision aids. And one guy quit his orthopedic residency and is running the company. So they're successful. They work with the Dutch government. So I've had an opportunity to create decision aids and use them in research. And I can tell you that they don't have the effect that you would expect they would. They definitely resolve decision conflict. So that's did I feel like I made a decision that I'm going to stick with, and that I'm confident in my decision. It does limit decision conflict a little bit, but it doesn't necessarily change treatment options and things like that. And what I've noticed, and there's other aspects of that. Another study we did was we said we need to create. There's a lot of evidence that basically that people don't care what you know until they know what you care, that old aphorism. And so we need to create that relationship. So we wanted to do this pre-visit conversation where we ask 3 questions. What's meaningful to you? What's your source of love and support? And what makes you laugh? And people loved the discussion. They thought it was a great way to frame the reason they were in the office. They thought it was felt very comfortable to them. It reminded them of why they were there in the office and what their goals were. But that was done by somebody other than the surgeon. And then the surgeon walked in armed with that information, and it didn't make any difference. So the key aspects to this, you can get the information from a website or a decision aid, and you can get the relationship from somebody else on your team. But ultimately, it's down to me. If I don't create that relationship, you're not going to hear or be open to anything I say. So it has to come through me, is my conclusion, and me after I've gained your trust. So I have to gain your trust, and then I have to guide you through the process of having an accurate inner narrative about what you're going through. And I'll tell you that I'll just finish with one thought, is that we're starting to move into this, and others are starting to move into this idea of phenotyping, mental health phenotyping. So we know the components of mental health as it applies to what makes you feel worse and do less when you have a musculoskeletal problem. So we put all those things in and let a computer find the patterns. And it found these patterns. It found no cognitive bias, or low, not no, nobody has 0. It has low cognitive bias, so you generally see things the way they are and you're flexible in your thinking. No distress, no depression, and no anxiety. No symptoms of depression, no anxiety. So that paradigm was 55% of people. So the average person, or most people. And then there's another group that have misconceptions. About a quarter of the people have misconceptions, but no psychological distress. So that's the person you can reorient pretty easily. So I think that large group of people, say 75, 80% of people, are going to be able to be reoriented in a single specialty visit. And you see that in claims data. People see us once and then they go off. People like Peter and I think that people are seeing us over and over. In the claims data, you see the vast majority of people, 70, 80% of people, see a specialist once. And then the next one is add a few symptoms of depression, another 10%. And then the most difficult category, lots of symptoms of depression, lots of symptoms of anxiety, and lots of misconceptions about what's going on. And there's no way with that 15%, and certainly that 5%, you may never get them to where they're thinking differently. The 15 or 20% that's going to be the tough relationship ones, you cannot do that in one visit. So I tell the people I work with, and I tell myself, forget about the medicine. Like you're going to figure that out at some point, but that's not the priority. The priority is the relationship.
Can I ask a follow-up question? You have certain doctors who are more empathetic and who deal with patients better, and you have some who aren't. How does this work out with relation to telemedicine? Do the ones who don't have the empathy, are they the ones that should stay off of telemedicine because it's going to make it even worse, their situation? Or how do you grade them on their ability? A lot of, like Cornell in New York, should they review some of the telemedicine consults that these people give, grade them and say, hey, listen, this is not working for you. You better deal with them personally or get into another line of work?
That's a great study idea. I don't know the answer. I'd love to study it. I can tell you my personal experience that when I'm in the office and there's a lot of stuff going on and I'm aware if I'm behind or I feel more pressure. I get wound up. When I'm sitting at home, I'm relaxed and I can kind of see the larger picture of things and keep myself even keel, strategize better. I'm probably equally noticing, but I manage my emotions better and I imagine the stress contagion better. I manage the stress contagion better. So for me, and I imagine others can probably do the same. I don't know if they give it the same attentiveness, but I think that's a great research question. I need to structure a study around that. Is it time to wrap it up, Ira, or?
Well, David, I think that was tremendous talk, and I think a lot of great questions. One thing I've noticed going forward is that it seems that the powers that be, i.e. the reimbursement folks, have pushed us all to be more and more of, at least the surgeons, more technicians than doctors. Even some of the primary care doctors are told they've got 7 minutes to see the patient, each patient at a time. And when we see patients, we're pushed more and more. In fact, even the new Medicare way of deciding how to pay us, it's either by time or by complexity. So the SOAP note is gone. That whole thing is gone. It's a matter of, this is your problem. This is how we're going to take care of it. And these are the complications or the issues that we have to address in order to take care of you. So we're going to need a different type of incentive, like you mentioned in your talk, to do things the way you're talking about, rather than push us further and further into the technocrat. I am just an operator. I will fix your knee. I will fix your hand. That's all I do. Don't expect anything else, which is the way things have been pushed. So what is the word from our societies about doing the things you're talking about?
Yeah, I agree with you. We have to set up a system to match the data. And so what I do right now is I kind of make the system work for me. But we need to make a better system. But what I noticed early on in my communication skills training, that long visits didn't do me any good. So you probably know what I'm talking about, Peter. So like, if you're in the off, basically, I would present my expertise, and then there'd be this series of questions. And then what came after that was, I thought I was teaching, informing, reassuring, right? I was arguing. It was an argument.
Mm-hmm.
And I was having an argument that there was no way I was ever going to win. I was arguing my expertise and opinions versus their reality. You will never win that. You will always be hated the more you try to explain, which they think you're trying to win the argument. So what I realized is my information transfer should be brief. And I realized I was coached, and I got a coach. I had a coach, and I got feedback. They sat with me, and my information transfer is less than 60 seconds. It's 3 or 4 bulleted points, less than 60 seconds. And after I deliver that, I do not engage in any data discussions, rationale discussions. I only empathize. Here's my expertise. Oh, you don't, that doesn't land well? I understand. It's hard to believe, but I don't try to convince them. And it works so much better. And then if a visit goes longer than 15 minutes, there's something else going on. For our stuff, Peter, we can have really quick visits and really quick, satisfying visits. You can look at our data. You can have nice, short visits that people love. If it's going more than 15 minutes, it's not usually the medicine that's complex. It's the illness that's complex. Mm-hmm. So what I've learned to do is incrementalize. And this is where I love phone calls and video, because I leave some gaps in my schedule. And if nobody needs me for that time, then I get to do my research or go have fun or whatever. But if they need me, then I can just sit. And actually, I'm usually checking my email. I'm usually double tasking while they just kind of go on and on and on, as an anxious person will. And I can just get in there with the empathy, normalize what they're going through, and try to gain their trust and guide them over to saying, yeah, I could use some mindset training. And even if it doesn't work, at least they don't hate me. I've listened. I've validated what they're talking about. And I don't want to do that more than once or twice. So I try to then negotiate how we get in, what's our strategy, and when is the PCP involved, when is my social worker involved who can do some cognitive behavioral therapy, and what are our goals. And the next visit, if it's with me, is going to be back to 15 minutes again. So I'm kind of hacking the system in a way. And now, by the way, now that we get paid by time, you if you spend that 45 minutes and you document what you did, you get paid for it. So it's just a matter of fitting your schedule, but you get paid for what you do. And I choose to do it that way. Everybody else has their own specific way, but I build the relationship incrementally, intentionally, strategically, so that I can get them to the care they need.
That's great. Who was you have to send me later on your coach. I have to talk to him.
I'm all about that. Let's talk.
David, I want to thank you for your time. I think that this was a really refreshing way of looking at how technology could, as you would say, hack our system to make us more empathetic, better communicators, save time, and as you yourself admit, sometimes double task and make sure that you can bring in the empathy while at the same time not missing an email. So
Yep.
I want to thank you for bringing us this, not only this information, but the ability to answer our questions, and hopefully we'll have more conversations like this at the Benjamin Rush Institute chapter. So again, my appreciation, and I hope that everyone who came for this event continues to come for many more in the future. So.
Yes, thank you so much for coming. Dave Ring, you did a great job. Thank you. Ira, thank you so much for running this. Tara Alfano, thanks again for your support, and thanks to New York Medical College and Touro University for giving us this platform. Thanks again, and we look forward to our next talk.
Thanks, everybody.
Good
Thanks
night.
for the great
Thanks,
questions.
David.
Thank
Have
you.
a great
Later.
New Year.
I hope you enjoyed today's edition of the Benjamin Rush Institute's virtual events series. To learn more about our educational programs and events just like the virtual events series, I encourage you to visit our website. While you're there, you can subscribe to the Benjamin Rush Institute's YouTube channel and link not only to all episodes in this series, but also to all of our past meetings, events, and conferences. And please consider supporting our work on behalf of the medical students we serve by donating to our efforts. Your support is vital if we are to continue to provide important educational programs and events just like this one. We appreciate your support, and please watch for your invitation to the next edition of the Benjamin Rush Institute's virtual events series.